You are the duty consultant of a tertiary emergency department. Your registrar has just seen a 58-year-old whom they are suspecting has taken an overdose of slow-release verapamil 3 hours ago. They have brought you the ECG to review and would like to seek your advice on management of the patient. His regular medications include aspirin, atorvastatin, slow-release verapamil, pantoprazole, and sertraline. His vital signs are heart rate of 36, blood pressure 90/55. He's studying 95% on room air with a respiratory rate of 24. His GCS is 13. He's losing points for eyes open to voice and some confusion. Your tasks are to interpret the ECG, provide appropriate management advice to the registrar, and address any registrar concerns. You will not be required to directly manage or assess this patient. OSCE will assess his medical expertise, priority, and decision making. Here's the ECG. Pause now and have a think, and then we'll get started. Yeah, hello. I understand you've seen the ECG for Mr. Smith, who we're worried has had a verapamil overdose. What do you make of the ECG? This ECG shows a rate of 30. I'm not convinced I can see any P waves. I think this is a slow junctional escape rhythm. In the context of this patient, I think that he has taken a highly fatty calcium channel blocker overdose and is in a shock state. Yeah, I agree. Are you able to take me through how you would manage this patient? Just so we're on the same page. Absolutely. So our priority is going to be resus and good supportive care. Then it's going to be to finish our risk assessment, make sure we've done appropriate investigations, ensure safe decontamination, and arrange appropriate disposition, which will be ICU. I'll talk through resus first. So for resus, we need to manage this patient in the resus room with full non-invasive monitoring. Airway is not a major concern at this point. For breathing, his SATs are 95% with an elevated respiratory rate, so we should put him on 6 litres via Hudson. Circulation is our key concern. The first priority will be to get to IV access and send off bloods, but specifically I'm interested in a VBG for BGL and lactate. Next priority is going to be I want him to have a fluid bolus. So I would give 500 ml bolus of normal saline, and we'll repeat that up to him having a total of 2 litres, with our endpoint being a capillary refill less than 2. Then our next priority will be to start him on calcium. So I want him to have 30 mils of 10% calcium gluconate, and that's to be given over 5 minutes, and then we'll be repeating that 3 times in the first hour. Our next priority will be to start him on high dose insulin euglycemic therapy. So to do that, I start him on glucose first, and then I provide insulin. So if his BGL is less than 13, I would give 50 mils of 50% dextrose as a bolus. Then regardless of his starting glucose, I would give him 5 mils per kilo of 10% glucose. Next, once we've got the glucose running, then we can start giving insulin. I would start with a bolus of 1 unit per kilogram of ActRapid. Then I would do 1 unit, start him on an infusion of 1 unit per kilogram per hour of ActRapid. To monitor this, I want 15-minute VBGs, and we're aiming for a BGL between 2.8 and 3. BGL between 5 and 11, and a potassium between 2.8 and 3.5. Our next therapy that we're going to start is I would start him on inotropic support. I think for this, I would start him on adrenaline infusion, and I'll aim at 3 mics per minute, but titrate aiming for a map of 70. To make up this adrenaline infusion, I would do 6 milligrams in 100 mils of 0.9% saline. So that will give you a concentration of 1 mil per hour, equaling 1 mic per minute. The other things we can try in terms of resus is you could attempt atropine of 600 every 5 minutes, so it's unlikely to work, but that may help with the bradycardia. And there's a limited role for pacing because you're unlikely to get mechanical capture, but it's not unreasonable to try. But we'll probably be looking later down at transvenous pacing. In terms of disability, he's GCS 13, so we just need to make sure he doesn't have agitation impacting on our care, and we'll be aware that he's probably not safe for activated charcoal at the moment. So that's for resus. Only other things on resus initially is once we start this care, he'll be reasonable to have an arterial line and or a central line. And so that's resus. Otherwise, just supportive care, just keeping him in a calm environment and managing any agitation. To complete our risk assessment, we need to really hammer down the history. So what I need to know is how much of the verapamil he's taken and find out if he's taken any co-ingestions and the doses of all of those. Then we need to, as part of our resus as well, but we'll be examining the patient. So looking at how unwell he is, but also if there's any signs of any other co-ingestants, such as evidence of serotonin syndrome. And then we also need to get an overview of his comorbidities, and obviously need to know his weight. So in terms of investigation, so we've sent VBG already. It's reasonable we do screening paracetamol, and because he's on aspirin, I'd also check salicylate level and also look at his gas evidence of metabolic acidosis, but it might be a bit tricky given that he's shocked to interpret that. In terms of decontamination, this patient should get activated charcoal. We can't give it to him now because he's altered GCS. But so we would be looking at him we would want to intubate this patient when he's stabilized and give 50 grams of activated charcoal via NG. But at the moment, he's too unwell to be intubated. It's too risky. In terms of disposition, this patient will be, once we've done our initial care, our initial resus, we should refer to ICU. Specifically, he's going to need invasive monitoring. He's going to need prolonged care, and if he does not respond well to our medical treatment, he'll be a candidate for ECMO. Are you happy with that as sort of a starting place? Yeah, no, that's super helpful. Is there any other teams that we should have involved besides us and ICU? Yeah, so later in this care, he's going to need input from the mental health team. And definitely this is someone that you would consider a detention order if that's required to facilitate care. And this is high lethality, so a clinical toxicologist should also be involved. Okay, that's great. Thank you so much. I'll get to managing this patient.